Good morning and welcome to the webinar. I'm happy to have the opportunity invited by my good friends at Dental XP and my good friends at Millennium Dental Technologies to share some time together with you to talk about the future of lasers. As many of you know, lasers have been very controversial in periodontics. Is this really science? Is it hype? Or is it really snake oil? In the next time together, we're going to find out how lasers are done, how they can be used to effectively treat periodontal disease. But before we do, I want to tell you a little bit about myself and my interaction with lasers, because over the years, what lasers meant to me was as follows. Pink Floyd. Living through the 60s and 70s, this is what I thought lasers were. But it really all started in the 70s with my mentor, Dr. Walter Cohen. He was able to see in a way that most of us could not. We were mired in resective periodontal surgery, which worked, but he was already looking to the future and knowing that the focus would be in the future on regenerating the lost tissues. We owe an amazing amount to Dr. Cohen's vision. What we're going to speak about today are several things. We're going to have an introduction to what lasers are. We're going to take a look at the objectives of periodontal therapy. We're also going to take a look at the objectives of LANAP, the LANAP protocol. We're going to find out how it works, the evidence, and the advantages. I've been reborn in dentistry 3 times, and this has kept me engaged. In the 70s, we had regeneration. In the 80s, dental implants came into their own and have become a staple of our practices. And today, an ability to do things in a way that we were never able to do them in the past. So let's take a look at what can be done. What you can see here is some inflammation between tooth number 10 and tooth number 9 and tooth number 10. Probing it, we see we have almost 10 millimeters probing. And when we look at the radiographs, we see a vertical defect and root resorption. How would we repair this defect? What would be available to us? What would be the results of typical periodontal surgery if we had to open a flap here and attempt a bone regenerative procedure? In a very short time, however, using the laser, look at the change in the tissue profile, the tissue contour, and the inflammatory response. We're now probing 2 millimeters, and radiographically we've gone on the left to the picture on the right. I don't think that there's any other procedure that we could get this sort of a result without the potential of a black triangle or a bad defect. Is this the only place that this happens? Well, let's take a look at this situation, a vertical defect on the mesial aspect of the upper right central incisor. In a short period of time, in 1 year, we are able to see all of this bone filling in, a regeneration of the attachment, and it continues to this day beyond what we see in this picture. Here's another situation, a little bit similar to the last. What would you do here? Palatal approach? Bone grafting materials? How predictable would it be to gain attachment, to gain regeneration? But with the laser, in a 14-month period, we're able to achieve this sort of result. It should be noted that many of the slides that you're going to see today have been given to me by colleagues around the world who have been using this laser technology. I want to pay homage to all of them. The other problem that we frequently face is the ailing, failing implant. What techniques do we have available to us today in order to regenerate the bone around this implant? Well, we can open it up, clean it out, try to clean the surface of the implant, and use regenerative procedures to attempt to regrow the bone. But with the laser, in 3 months' time, we were able to achieve this. Can we do this every single time? No. But it is absolutely possible, and you will see many evidences of that today. This is a typical vertical defect that we often see on the distal aspect of a molar or in other places. Clearly, there are etiologic factors here. You can see the calculus on the root surface. But this defect, would it be repaired if we simply scaled and root planed using typical instrumentation? I don't think so. This is a vertical defect that is probably a combination 1, 2, and maybe a little bit of 3 wall. Using the laser, however, we can get some dramatic results in growing back some bone, regenerating the lost tissues, and hopefully getting true regeneration. In this picture, we see something that shows us that these teeth are being held in by a calculus bridge. Is there an opportunity to regenerate tissues here? Are there pluripotential cells available that we can tap into? Well, one wouldn't expect in such a short time to be able to achieve this, and the repair goes on. Within probably a year to 18 months, the bone around the root surfaces will look a lot like the bone apical to it. Here's another situation. We can look at the etiology of this as being an open contact, and we can contact and attempt to do some sort of regenerative procedure. Our typical regenerative procedures, though, would not be predictable here also, because this is probably a 1-2 wall combination. However, in 10 months after laser therapy, not only has the contact spontaneously regenerated itself, but also we've got a tremendous amount of regrowth of bone. I'm a great lover of quotes, and this quote I think is apropos to what we're talking about. Oliver Wendell Holmes said, "Man's mind, once stretched by a new idea, never regains its original dimensions." How does that relate? Well, we need to start thinking about what we're doing through a different set of eyes. We need to be able to think of it not with the old views, but potentially the new views. We aren't going to toss out the baby with the bathwater. We still are going to look to our traditional procedures, but perhaps we have procedures today that will give us different opportunities. We can't forever look back without taking a look at what we're able to accomplish today. Go through, because we have to, some basic laser physics so that we can understand how this whole procedure works. What does laser stand for? Well, Albert Einstein in the 50s coined the term laser as an acronym: light amplification of stimulated emission of radiation, LASER. So let's talk a little bit about this, because it's all about light and how light is manipulated. If white light goes through a prism, it breaks into its component parts of multiple different colors. It gives us all colors and all wavelengths. On the other hand, when we have laser light energy, we have to have a very specific type of light. It's monochromatic rather than polychromatic, as we just saw. It's collimated, which means unidirectional and parallel. And it's coherent, which means it's in phase at a single frequency. In order for us to generate laser light, we have to have it be monochromatic, collimated, and coherent at one and the same time. How do we accomplish this? Because if we can use those laser light beams to deliver highly monochromatic and highly directional energy to modify tissue such as in LASIK surgery. With proper use of the laser, we're able to ablate 1 or 2 cell layers very safely of the eye surface and modify someone's vision forever. So how do we get this? Well, first, the laser itself has an active medium. This determines the wavelength's power and its energy. We pass the light through the active medium and we can determine the wavelength, power, and energy. When it's there, it's multiplied many times by hitting mirrors and being amplified. And then it's generated at a wavelength specific to the application. So this gives us exactly what we talked about moments ago, so that we can use this in the treatment of various tissues. How do we get the name for a laser? Well, the name for the laser is given by its active medium. So we are familiar with such lasers as carbon dioxide lasers, holmium lasers, but the Nd:YAG is the most commonly one used in medical applications. What does Nd:YAG stand for? Neodymium yttrium aluminum garnet. It's a mouthful, but it refers to the particular crystal that is used in the active medium to generate the laser energy that we want. It is the most commonly used laser in medical applications. So it's relative to the kind of wavelengths that we have. So we have wavelengths that go all the way from cosmic rays to broadband rays. But we're going to look at this in a very, very small, from ultraviolet light to infrared light, and we're going to be at 1060 nanometers. That's the critical place in which the laser energy is going to give us the ability to do the things we want to do with the tissues. So let's talk a little bit about the laser beam. They're pencil-thin beams traveling at the speed of light. So in this diagram, we show that light can be reflected right off the water, in which case it's doing nothing, or it can be absorbed by a tissue, or in this case the rock, in which we can alter it. It can be transmitted, in this case through water, where it is also not doing anything, and it can be scattered. So what we need to remember is where the laser energy is absorbed, it can be used to do something to tissue. Once again, I want to say that it is critical the wavelength that we're using. And the particular laser, the Periodontal, is operating at 1064 nanometers. This wavelength is what determines what the tissue interaction is. In other words, what it does to the tissue, and then, of course, how we can use it and what therapeutic applications we can use it for. This graph, which looks a little bit complicated, is just showing one very important thing. Our laser at 1064 nanometers is absorbed by certain tissues. Once again, the tissue that absorbs it can be altered. So melanin, hemoglobin, protein all absorb laser energy at the 1064 nanometers. However, it's transmitted, as we showed in the last picture, through the water. So consequently, the hemoglobin's being changed, the melanin's being changed, the protein's being changed, but not the water. Why is this important? Because tissues that absorb the laser energy are the ones that can be treated. How does this work? Well, it's important to know, once again, that the pigmented tissue at the top here absorbs the laser energy, is the only tissue altered. So it can pass through the rest of the tissue without doing any damage. So we absorb it where we need it to treat the tissues, in our case, the inflamed tissues, but where it is unpigmented, it passes right through that tissue without altering it in any way. Let's talk a little bit about the various emission modes, because that is quite important to our use of the laser. A continuous light source, you're all familiar with, is an electric light bulb. A camera flash is a single pulse. And a strobe light is a repetitive pulse. What's important about this is the repetitive pulses and the very, very short nature of those pulses. The shorter the pulse, the greater the peak power. And what is unique about Millennium's periolase is that it produces very, very short pulses, as we will see later, which produce great power at the place in which we want that power to be. The peak power actually determines the specific tissue effects. So we want to be able to do ablation of diseased tissue, and later we want to be able to coagulate or get hemostasis. So this laser, by altering its output, we can get all of these things. Other things such as fragmentation and vaporization can also be achieved. So how does it work? A little like this. The laser beam affects the tissue in this way. It's passed through one thing into the tissue and alters it. Here's a little video that'll tell us about the laser.
This is where bacteria live and build a neighborhood of its own that destroys healthy gum tissue and bone that holds your teeth in their proper position. There are specific germs and bacteria that cause gum disease. The periolase laser is designed to target and eliminate selectively only the diseased tissue and germs, dissolving toxins and leaving the healthy tissue unharmed. The laser tip is then removed from the pocket and set aside. In the next step of the procedure, ultrasonic cleaners as small as the laser fiber tip are used to remove the hard deposits we call tartar or calculus from the top of the teeth and roots. These instruments use sound waves to vibrate and break apart the hard mineral calcium deposits, with water flushing away the debris and cooling the instrument tip. Some hand cleaning instruments may be used at this time to remove any remaining hard calcium deposits. Then the laser is used again at the bottom of the pocket to remove any remaining diseased tissue. This pass of the laser also sterilizes the tissue and bone and completely eliminates the bad bacteria, germs, and toxins. It also stimulates the formation of a blood form, contains fibers that reattach your tissue to the tooth surface and seal out debris and bacteria like stitches would, and creates the right environment to cause the bone and other soft tissues lost from the disease to grow back.
This animation shows us very clearly exactly how this process works. So it would be useful for us to take a look at a video of the actual procedure. Step number one, at a specific level on the laser, we interact with the tissue, slight carbonization of the diseased tissue, and we are troughing, essentially attaining access to the pocket. This is a lot like the troughing that's done in crown and bridge. We carefully and slowly around the sulcus, gaining access without any discomfort to the patient, without any of the tissue. Once we have adequate access, we are able to then insert the cable away to the. In doing this, we are able to reach as possible and interact not only with the tissues, but also with the bacteria. As you can see here, until we meet as we possibly can go. We do this in sort of J strokes, a little bit like a curette. Now we use the piezo device, and this piezo device will separate the tissue, completely cleaning out the pocket, removing diseased tissue which we have already interacted with the laser fiber tip, as well as removing accretions from the root, calculus, etc. 3 different tips allow access, and as you will see, the tissue, much as if we used a scalpel, elevated the tissue for complete access. Once you can see this factor, you will be able to see that this is surgical intervention, and we are able to alter the tissues in so doing. Here you can see the bleeding that's been affected and the locator, which will allow us to get to areas we've been able to get to, calculus and debris. The tissue is completely separated, much like an elevated flap. Following this, we go back to a different setting and we use the fiber optic tip. The color of the hemoglobin is what allows the laser to interact with it. And as you will see, all we need to do is do this completely circumferentially around the tooth and reposition the tissues strictly with our finger. That will serve as our membrane, allowing the healing that we get from this procedure routinely. So let's look at a couple more clinical slides. Here we have a defect. We have a poorly fabricated bridge. We've got a tipped tooth. We've also got plenty of etiologic factors such as calculus. And without modifying the bridge in any way, in 6 months we were able to achieve this result. Here we see something that you see in your office very frequently. A 10 millimeter pocket, an acute infection, perch a cone into the pocket, which goes to the depth, and we can actually see where this periodontal abscess has broken through the tissue at the level of the mucogingival junction. Here it is 4 years later. The only thing that was done, no flap was elevated. We used the laser, it interacted with the tissue, and we promoted healing. Once again, here you can see a pocket in the digital probing of this pocket. We can see that it is close to 15 millimeters. In a short period of time, this is the initial presentation. This was after 4 months. And at 11 months, we can see we've got complete regeneration of the bone and presumably at a histologic level, the periodontal ligament and the cementum. Can we consistently do this with implants? Well, here we have a pocket that is probing to the apex 360 degrees around the implant. Is there any other procedure that you can think of where we could predictably get this type of a result in 9 months? Once again, Marcel Proust said, discovery is not seeking new lands, but seeing with new eyes. I hope so far that you've begun to think in a different way and seeing the tissues that we deal with on a daily basis through a new set of eyes. So what are the objectives of periodontal surgery? Because we have to understand the objectives of conventional periodontal surgery before we can understand how the Lenap procedure has the same objectives but gets there in a different way, and perhaps with better results. So, the first rule of periodontal surgery is we want to open flaps to gain access to the roots and to the alveolar bone. This will allow us to increase the effectiveness of root debridement. We can also modify hard and soft tissue defects if we've opened a flap. We can establish physiologic architecture with osseosplasty and osseous resection. We can repair bony defects by using a variety of bone regenerative procedures using autogenic grafting or allogenic grafting. And we can correct anatomic anomalies using membranes. We can augment the alveolar ridge defects and sometimes grow back the lost bone. And I say sometimes because it's important for us to know that this is not totally predictable. But what is regeneration? It has been forever our gold standard. It's new attachment, and that includes new bone, new cementum, and new periodontal ligament. It is very important that we understand that this has been our goal since the beginning of the specialty of periodontics. New attachment has been very, very difficult to gain. It is indeed an elusive goal. However, our forefathers, people like Frank Bube in 1947, with vertical defects of this sort, were attempting to regain attachment. And with procedures such as splinting and scaling and root planing alone with no surgery. In certain cases, they were able to regenerate a substantial amount of bone. Henry Goldman, another one of our forefathers, in 1949, showed this in a publication. He expected to take out the first molar and perhaps save the second molar. In 6 months' time, however, he was able to get almost complete fill on the mesial aspect of the second molar and some fill on the mesial aspect of the first molar. So these folks already were looking for the idea of regaining tissues, and they weren't thinking periodontal surgery because it wasn't until 1948 that Saul Schluger showed us how to approach the bone with flap procedures. Another thing that we do in conventional periodontal surgery is we attempt to repair mucogingival defects, and we have a variety of methods for doing so, such as grafting, soft tissue grafting that you're all familiar with. The objectives of periodontal surgery, the single most important objective is to provide soft tissue contours after pocket reduction. We want to enhance plaque control and maintenance. These are the reasons we do periodontal surgery, the conventional periodontal surgery. We also want to improve aesthetics. But does it do this? The screen on the left shows us conventional flap surgery. The screen on the right shows us healed tissues. We may have eliminated pockets, but have we improved aesthetics? Have we enhanced plaque control? Is it easier to clean these spaces? Do we have to take another look at this to determine whether or not this is the best way to get the result we want? Are these tissue contours ideal? Or are they the result of a surgical intervention and they may not be perfectly ideal in the long term? They certainly aren't aesthetically. So what are the objectives of LANAP? Are they dramatically different than conventional periodontal surgery? Is there some sort of mystery magic in this laser device? Are we going to abandon 100 years of clinical experience? Are we going to abandon animal and human research results that we've lived with? Are we, like Tevye, going to throw out the door tradition and conventional wisdom? Or are we going to look at it in a different way? Is there really controversy here? Or are these two different methods for achieving the same result? So what are the objectives of LANAP? We need first to define what LANAP is. It stands for Laser Assisted New Attachment Procedure. The definition of that is cementum-mediated new attachment to the root surface in the absence of a long junctional epithelium. And the folks at Millennium Dental Technologies have developed the PerioLase MVP7 laser, which is designed specifically to gain new attachment and to treat periodontal disease in a different way. It's the first and only FDA-approved laser that was permitted to make such a claim. There are many, many lasers that we deal with, and we'll get into that a little bit later, but they don't all do the same thing and they don't operate the same way. This laser is unique to our profession. So let's talk a little bit about the differences here. With conventional periodontal surgery, we frequently end up with a long junctional epithelium. We may reduce the inflammation, we may reduce the pocket depth. What we want to get, however, is new attachment to the root surface in the absence of a long junctional epithelium, such as we see on the right side. We want true connective tissue attachment. We want regeneration of bone. We want the attachment of the periodontal ligament fibers into the cementum. So let's talk a little bit more about the objectives of LANAP. We want to gain access to the roots and alveolar bone. That's exactly the same as what we said before with respect to conventional periodontal surgery. However, if we have a pocket of this depth, as you see on the right-hand side, you can see the laser beam reflecting through the tissues. Can we get there with conventional instrumentation without elevating large flaps? I think not. How we can do this is with the laser fiber optic cable. It is the thickness of 3 human hairs, about 0.3 millimeters. So we can enter a pocket without elevating a flap, and by using the laser energy as we showed you in the video, we can get to the depth of that pocket and interact with the stem cells. We can interact with the bone itself. We can interact with the defect. In periodontal surgery, with using a blade, we want to remove the sulcular epithelium. However, with the laser, we can do this very, very precisely, taking only a couple of cell layers rather than a whole lot more tissue being removed, because we produce precise ablation. I like to define ablation as kind of like a microscopic potato peeler, in which we're taking away the diseased lining of the tissue, and we're doing it in a very precise fashion. We want to remove calculus from the roots, just like in conventional surgery. So we're using the piezo scaler that's been designed for this technique, which is highly powerful and uses 3 very specifically designed tips to get there. We aren't throwing out traditional hand instrumentation. We're using the piezo scaler as well as hand instrumentation. So there's nothing different about this than conventional periodontal therapy. Just doing it with different instrumentation to achieve the same results, maybe more efficiently with less of the side effects. So we wanted to debride inflamed infected connective tissue. We said before that the laser energy at 1064 nanometers is interacting with tissues that are colored. In this case, the laser fiber has a bactericidal effect. As well as reaching the depth of the pocket, it throws out the laser energy which enters the tissue and interacts with the pigments. So we can do things without having to cut the tissue away, and we can get access to the root surface, the depth of the pocket, and in the soft tissue. These bactericidal effects result from the laser energy's affinity for colored or pigmented bacteria. And we all know that the bacteria that we deal with are black, red, yellow, and orange Bacteroides. So this is a perfect situation for our laser energy, which is seeking colors. That is the way it is allowed to interact with the bacteria. So, just like in conventional surgery, we want to debride inflamed infective connective tissue in the pocket, along the root surface, in the soft tissue. And as you can see in this histologic slide, we know that the root surfaces are very irregular. Can we plane this completely smooth and get into the interstices and kill the bacteria? I don't think we can do this very predictably, but with laser light energy, it will seek and find the bacteria and the colored changes within the surfaces of the root. The next thing that this does, which is kind of unique, is we get rapid hemostasis, as you saw in the video. The specific wavelength is attracted to hemoglobin. Remember that hemoglobin is red, and literally we are poaching the blood and creating a thermal fibrin clot. This is an important factor in this particular technique, as you will soon see. This is what it looks like after 24 hours. We have a fibrin clot at the orifice, and you can see that the tissue is not highly inflamed. It doesn't look like it's beat up. It actually looks like it is healing tissue that you might see in conventional surgery several weeks later. This is 24 hours later. So what does this clot do? Well, it facilitates the potential for regeneration by sealing the pocket, so that keeps anything from going in from the outside. It creates a physical barrier like a membrane. So you have to think about this as if we were doing conventional regenerative procedures using a membrane, but in this case the membrane is at the orifice of the pocket. It creates the barrier, and it prevents the downward growth of epithelium. What's unique about this, really unique, is instead of the conventional way of getting healing, this promotes healing from the bottom up, where the pluripotential stem cells are, rather than from the top down. And I want to repeat that. It's promoting healing from the bottom up rather than the top down. Our membrane is the fibrin clot, and the cells of the periodontal ligament, the bone, etc., can heal from the bottom up, regenerating themselves. This is very unique to this technique. This is the old-fashioned way. In addition, we manage occlusal pathology. This is quite important because almost always when we have periodontal disease, we're going to have shifting of teeth, loss of attachment, and we're going to see mobility. So a very important part of this therapy is occlusal adjustment. Or, in addition to occlusal adjustment, we may decide to splint teeth as needed. Let's think about this. Is this radical thinking? Is this completely new? Is this like saying that the earth isn't flat, the earth is actually round, as Aristotle showed us? Are we breaking idols? Is it iconoclastic? Are we still thinking that the earth is the center of the universe instead of the sun, which Ptolemy and Copernicus showed us? Is this subversive thinking, this new idea about how to treat periodontal disease? Is it kind of like what Pasteur and Koch showed when they showed that germs cause disease, not other things? Rather, I'd like to think about it as revolutionary thinking. Benjamin Franklin showed that lightning was truly electrical. It was innovative thinking when Charles Darwin, with his theory of evolution, showed us how things develop. I think this is groundbreaking, a lot like Albert Einstein, who early in the 20th century showed us the theory of special relativity. But they are ideas that are spectacular in terms of what we can do today that we couldn't do yesterday. So, LANAP is a precise treatment protocol which combines the best aspects of laser surgery with well-established principles of periodontal therapy. We are not throwing the baby out with the bathwater. We are getting the same results, maybe even better results, using a different technique. We are not trying to do something different. We are still looking to the same endpoints, but we'd like to be able to do it without some of the side effects that have been traditionally associated with periodontal therapy. Ed Zinman said back several years ago that LANAP is now a part of the standard of care for the treatment of periodontitis. It is accepted by all of the insurance companies today, and it is beyond reproach at this time. So let's look at some more clinical examples. Here is a vertical defect on the distal aspect of a premolar. We have a fixed bridge in place. We would have to flap from underside of this pontic, and we would have to get access, and we would attempt one of several bone grafting techniques that are available to us. Would this achieve the desired effects predictably? Or, with laser, could we get something like this inside of 9 months? I think this is a very dramatic result, and it is still filling in, and the bone is becoming more solidified. And I think if we looked at this histologically, we would see a very substantial change in the relationship of the attachment apparatus. Here's another situation. How would we get access with the narrow root proximity here? How would we be able to get a membrane in this area? How would we be able to connective tissue graft in a way in which we could gain attachment and better soft tissue and pocket elimination all at the same time? But in 4 months, this is what we're able to achieve. Furcation defects have always been the bane of our existence. We can't always get complete fill, but with the laser we often can get significant fill. Here's a situation in which we have a super erupted tooth, we have an open contact. Neither of these were treated. I'm not saying that we shouldn't treat them, but in a short period of time, this is what was able to be achieved. If we now do the occlusal adjustment and perhaps splint or use a restoration to close the contacts, I think this would be self-sustaining for many years. Once again, let's take a look at a failing implant. Can we predictably get a result which will get us back to go? This is in the anterior region. If we had to elevate a flap, we are always at risk for ending up with a black triangle or an opening that we don't want to deal with. Using the laser, we can achieve almost perfect health with the bone back to the level of the shoulder of the implant, just below where the abutment inserts. So we need to think about all of what we've said so far. Because when this instrument was introduced, there was tremendous controversy about it. And what Schopenhauer said was that all truth passes through 3 stages. First, it was ridiculed, and for sure the laser was ridiculed as a treatment modality that was effective for periodontal disease. It was then violently opposed by many of our colleagues. But today, it's accepted as being self-evident, as if it was always that way. So how does it work? You need to understand that all lasers are not created equal. We're not here to try to say that any laser is better than the other, but certain well-defined lasers, like the Millennium Periolase, was designed specifically to have an effect on periodontal disease, whereas other lasers may attempt at that, but they weren't designed specifically to do it, nor have they proven with research that's published in refereed journals that can show it. You can't change physics. One laser is not the same as another. So, the Nd:YAG laser that Millennium has developed is a free-running fiber optic laser. What free-running means is pulsed laser. And as we said previously, short pulses produce greater power. Ultra-short pulses produce favorable tissue responses without any collateral damage. So it affects the tissues that are diseased and passes through the tissues that are not diseased, so it doesn't do any burning or damage to adjacent tissues. This is critical. This laser that's pulsed is a bullwhip. Other lasers, which are continuous, tend to be more like a bulldozer. So think in terms of the crack of that bullwhip. There's minimal depth of penetration. The thermal footprint of this laser is small. Longer pulses produce more peripheral tissue damage, as shown in the histologic section to the right. The far right shows what happens with ultra-short pulses, where we do not have any significant defect or negative change in the peripheral tissues. So the whole issue here is the shorter the pulse, the better the situation. Continuous wave lasers, like the electric bulb we showed earlier, produce a non-stop flow of photons. So in other words, until you turn it off, it's entering the tissue and being affected by all of the tissue. It passes through. So if it passes through the tissue, it's not only treating the tissues that need to be treated, but the tissues adjacent to them and creating damage. These pulsed lasers, such as the periolaser, produce brightness at depth. What does that mean? It means that it has a beneficial effect at depth without collateral damage to adjacent tissues. This is again the 1064 wavelength, which targets pigmented tissues. Our pigmented tissues are such as P. gingivalis, bacteroides, and pathologic proteins. Indeed, this laser is a heat-seeking missile for pigmented bacteria. The laser energy goes just for the colors and affects the diseased tissue and kills the bacteria. The free-running pulse laser produces beneficial effects at depth and distance without damage to adjacent tissue. This is an important concept. I can't say it over enough. It produces beneficial effects where we want it, at distances where we need it, without any damage to the healthy tissue. It reflects, it scatters, and disperses in the non-pigmented tissue, which is not the diseased tissue. But it is highly absorbed by the pathologic pigmented targets. It's kind of like a stealth fighter. It leaves little evidence that it was there. It only affects the tissues that need treatment. Conventional treatment affects all of the tissue, both diseased and adjacent tissue. It's kind because it's only on 0.2% of the time and off 99.8% of the time. So it allows the tissue thermal relaxation, as opposed to the picture we showed you of the fire hose and the bulldozer, in which case there would be a much greater time on, less time off, allowing for less thermal relaxation. There's instantaneous high impact on the diseased tissue because of the ultra-short bursts. The substantial time off permits maximum tissue recovery without damage to adjacent tissues. So what's the bottom line? The bottom line of the Millennium Laser, the periolaser, is that it develops high peak power. It is very precise because it can be delivered exactly where you want it. It is selective. Only the pathologic tissues are affected. If no other slide is important here, it's important to remember that this laser, operating at 1064 nanometers, is intense, it's precise, and it's selective. I don't think there's any other surgical approach that we have in our armamentarium that can state that unequivocally. It is indeed different. So let's get back to some of our clinical examples. Here's a situation in which we have a massive amount of bone loss on an upper canine. And at 1 year, we're able to regenerate the tissues, as you can see here. Here's another situation where it would be most difficult with conventional flap surgery to deal with this. Are there cells in there that have the potential for regeneration? Well, look at this picture. There are problems in doing conventional surgery here. You've got root proximity problems. You've got access problems. But with a 0.3 millimeter diameter fiber optic cable, we can get all the way down, as we've done with the gutta percha cone here, and we can get to the area that we want to treat, and at 1 year we get amazing results. Here we have this shown with a 3D reconstruction using a CT scan. We can see the defect on the mesial aspect of the upper left central incisor. And we can see the fill that we've gotten of that defect. Now, we didn't get any more coronal bone growth, but we certainly can see in the left-hand picture of the 3D reconstruction that we have gotten bone fill and regeneration of the lost tissues. Here's the situation radiographically, a tremendous defect. This tooth would probably be extracted. But at 1 year, not only is the tooth still there, but it's in function. Once again, a mesial defect, deep defect. How would we treat this? How would we avoid black triangles? How would we avoid a defect post-surgical? This is what we were able to achieve at 7 months. So what's the evidence for all of this? Well, the first research in a refereed journal in the IJPR was by Ray Yuckner in 2007, in which he did a histologic evaluation, a human histologic evaluation on new attachment. There are very few studies in our literature on human block sections. Ray did that in 6 human beings. He treated 6 teeth with moderate to severe periodontitis. All teeth were scaled in root planes, 1 of each pair treated with the laser. The teeth were all removed in block section after 3 months and processed histologically. The LANAP results were greater probing depth reduction. We gained more new cementum. There was no evidence of histologic changes, of adverse histologic changes, and 5 of the 6 control teeth had long junctional epithelium and no new attachment. So these cases do support the concept that LANAP is associated with cementum-mediated new attachment and regeneration in periodontal tissue in humans. This was the first research paper to show this. Let's take a look at the histology that Ray showed us. This section alongside the root shows us the depth of a pocket. What we can see is a notch that was made in the cementum, and above that notch we can see new cementum, we can see new bone, and we can see new connective tissue attached into the cementum. And in addition, we see a very short junctional epithelium. In the control patient, we can also see a pocket. And what we see is the notch at N, the bone level, which is lower than the notch. There's some cementum and a very long junctional epithelium. So there's no new attachment in this particular situation. So what were the changes that he achieved? Well, he achieved new cementum with the LANAP procedure in 6 out of 6 patients. There was new connective tissue attachment in 4 out of 6 patients, and there was new bone in 6 out of 6 patients using the LANAP protocol. What are the advantages of LANAP? Some recent research has shown beautifully, histologically, you can see the cementum and the new cementum and the cementoblasts laying it down and the new periodontal ligament fibers. This work was done by Dr. Mark Nevins in a 9-month human block study that is in publication in the near future. He did this with Professor Peter Schupak, who did the beautiful histology that you see here. So what are the advantages of LANAP? It's a viable alternative to traditional periodontal surgery. It is less invasive. It is less traumatic. It is selective of only the diseased tissue. It penetrates the soft tissue where the bacteria reside. I don't think we can say the same about our conventional surgery without producing effects that we would prefer not to have. It stimulates stem cells, which promotes regeneration. It's bactericidal to pigmented pathogens. It alters the calculus, making it easier to remove, and it neutralizes endotoxins. Can we say that about conventional periodontal surgery? There's minimal postoperative discomfort. We get rapid hemostasis, where we can get the clot the fibrin clot, which is one of the keys to the results we get. There's minimal recession, which we can't say in conventional surgery, which leads to less postoperative sensitivity, quicker healing, and a better ability of the patient to affect plaque control without having to deal with large spaces between the teeth and sensitive roots. So let's look at a few more clinical examples. Here's an ailing-failing implant. 12 millimeter pocket. At 12 months, we're down to 5 millimeters. 24 months, we have even more fill. Once again, a defect of almost 12 millimeters. In 10 months, we're able to achieve the following. This is unique to this procedure. I personally have been teaching periodontal surgery for years, and we have always looked for a method that was less invasive, that caused less pain, and that could produce more predictable results. I was probably least likely people to adapt this technology. I was skeptical from day one, but when I started to see results like this, I changed my mind and could never go back to the old way. Here's a defect. How would we treat this? At the bottom, it might be 3 walls, but it is probably 10 to 12 millimeters in depth. Can we consistently go in, bone graft this, and expect to get full? Here we see at 13 months a tremendous amount of new attachment. Here's a dental implant. It's literally failing. We took the crown off this tooth. We considered the surgical methods, but we attempted this using the laser. And now in 14 months, we've resolved the problem. This implant won't be lost. We don't have to go through a grafting procedure. We don't have to replace another implant. We don't have to make a new crown. And most importantly, we don't have to put the patient through multiple procedures. So, we need to ask some questions and answer them. What treatment are you going to offer your patient who says, I've heard that when you go to the periodontist, all they want to do is cut your gums? How will you respond to that? If your patient says to you, I've already had periodontal surgery and I never want to do that again. I can't tell you the numbers of patients that I've seen who've had periodontal surgery 2 and 3 times. Some of them my own patients. What are we going to say to them? Do we have something to offer them that's unique to the profession today? How about the patient where we have carefully scaled in root plane? We've used local antibiotics, but we've failed to achieve the desired result. Are we going to do conventional surgery, or do we have another tool at our hand that we can try? How about patients who have medical problems? A patient who's on Plavix or Coumadin, or in fact bisphosphonates. Do we want to do invasive surgery on these patients? What are you going to tell your patients? Will you offer them options? How about a patient who's just recently had a full mouth reconstruction and now they're developing pockets all over? Are you going to recommend a surgical procedure which is now going to expose the margins and expose the cementum of the root and potentially have to redo the reconstruction? Or do we have something that is better, faster, less painful, and more likely to affect the cause of the problem? You know, in conventional periodontal surgery, essentially we are treating the effects of the problem. In laser or LANAP surgery, we're affecting the cause of the problem and attempting to allow the body to heal itself. Summing up what we have looked at so far, I like to think of a quote by Frederick Jensen, an 18th century philosopher, who put it in perspective when he said, "What we think we know today shatters the errors and the blunders of yesterday, and tomorrow is discarded as worthless. So we move from bigger mistakes to smaller mistakes. This is true of all therapy. No method is final. And when we look through the eyes of the past, we see one method of doing things. When we add what we know today, we can see a much bigger picture with much better opportunities, and we can deliver things to our patients that we were never able to deliver in the past. And I never end a lecture without using this quote as well, because each of us has stood on the shoulders of other people who came before us and showed us the way. In my case, it was Dr. D. Walter Cohn, Dr. Morton Amsterdam, Dr. Herman Korn, and Dr. Leonard Abrams. These were the men who shaped me, who taught me the skills I have, who made me question what I was doing, who gave me the opportunity to learn the skills and to accept new ideas and to move forward with the new technologies that can give us the opportunity to offer our patients things that we were never able to offer them before in ways that we were never able to offer it to them before. And I'd like to thank you for spending the time together. Please feel free to contact me at my email address, istephenbrown@aol.com. Please feel free to go to our website where there's a great deal of information on laser and the LANAP protocol and the words of patients who've had it done. Please go to www.theperiogroup.com. I'd like to thank all my friends at the Dental XP and my colleagues at Millennium who have done an amazing job in educating the public and in training dentists in ways to deliver this therapy effectively.